Now I pass on to the next topic. This has been sponsored by Narayana Hospital, which was previously known as Rabindranath Tagore Hospital. And topic is on critical care. And the speaker is Dr. Sourin Panja. And he's an eminent critical care specialist and taking up the charge of critical care in Narayana Hospital. And I invite Dr. Sourin Panja to come up. Sir has done MD in internal medicine and FNB in critical care medicine, European diploma in intensive care as well. Please, sir, we are waiting for you only. So now, another request, please stick on to your time of speech. Thank you, sir. Dr. Panja here.
Good morning, everyone, and at the outset, apologizing for my delay because of the little bit of rain and others. And I am really privileged to be here. I must thank the IMA South Calcutta branch for inviting me for this lecture. And the time allotted is 15 minutes, though this lecture will be little elaborate, but I will try to cover within 15 minutes time. So I will topic on some of the changes that has happened and that is continuously happening in the your field of your sepsis. Sepsis is basically in day in out from whether I am working basically specializing in critical care medicine after done my MD in medicine. But I think this challenge is for everyone from every specialty, whether I am from medicine or other thing. So sepsis is one of the major cause. So if there is any infection, so ultimately what happens, there is organ dysfunction. And because of the why organ dysfunction? Because sepsis actually changes some of the immunological change inside body. It is not only the bacteria, but bacteria and our body immune cells, they are interacting, they are producing so many substances, we call them as cytokines, and ultimately they lead to a cascade of organ function. And there are every time new development in the management of sepsis, new understanding. So on the basis of the year, last surviving sepsis campaign, because in our field, so every 4 to 5 years, there is one update on the sepsis globally that happens, and usually and as intensivists, we follow that guidelines, and there are so many facets. But I will try to cover whatever is basically necessary and what problem we are facing, that I will cover. And accordingly, there are different type of gradings. So some there are evidence, means good number of studies showing, okay, there is important. And some is basically what we call it as evidence-based medicine, when there is some study and that is supporting some practice. But other than that, we have our own experience. So what our experience is telling, that is also incorporated in that. Because not only that, always you will get some study and robust result. So that's why it is important. So I will not go into the details. So what are the important aspects of the sepsis aspect? So sepsis is basically any patient is coming, first we need to get the diagnosis. And after that diagnosis, whether it is really infection or other causes that is causing the similar type of presentation. As for example, if a patient is having infection and if a patient is having pancreatitis, you will find some of the features is very similar. So how can we differentiate? That's why it is screening resuscitation, and how we are coming to the diagnosis, and then the management. And not only the management, we know that any sepsis patient, they sometimes get hypotensive, what we call it as septic shock. So that time we need to give fluid resuscitation. But question is how much fluid we need to give and what will be our target blood pressure. So that is also important. Then there are additional therapies that I will not cover much. And then there are what will be our goal of care. Because on the day one, we need to, patient family will want to know what is their diagnosis and what will be the ultimate outcome. So otherwise, there will be sometimes in third day or fourth day, the patient family may ask you that why your doctor don't tell me that, okay, my patient is so sick. So in the screening and resuscitation, screening is basically mostly in the day one, we are clinically screening because culture report is not available. So there are different type of the tools, like particularly the SARS or systemic inflammatory response syndrome. That is very old, age-old concept, but that is still in a good phase for the diagnosis of the sepsis. So that screening for the diagnosis is whether there is systemic inflammatory response. Along with that, we are doubting that there may be some urine infection or chest infection. That is the screening. And couple of years before, there was SOFA. So SOFA means basically sequential organ dysfunction. So if a patient is having some of the organ function is okay, the organ function is normal today, and tomorrow I have seen that the liver function or the kidney function is altering. So if that score there is some increase in the organ dysfunction, so there is a possibility of sepsis. So that's why the screening is important, and I am just discussing, then I will discuss about the initial fluid bolus resuscitation target. And about the different type of scoring, there is a few scoring. Systemic inflammatory response syndrome is very good one, and SOFA score, another is basically, there is score means basically how is the liver function, how is the kidney function. So that way we can keep one score on the day one. If there is some increase in the score or organ dysfunction is there, probably this patient might have sepsis. And this QSOFA was being devised in 2016, and basically that was basically three components: the respiratory rate, altered mentation, and systolic blood pressure less than 100. Out of that, if there is more than 2 criteria is positive, probably this patient is suffering from sepsis. But that was more true for the in the field or sometimes in the ward level. But in the critical care inside, that may not be so relevant. So that's why I will suggest that okay, systemic inflammatory response syndrome as well as some organ dysfunction. If we monitor, if there is doubt that this organ dysfunction is happening, so probably this patient is suffering from sepsis. So sepsis and septic shock are basically medical emergency, and the treatment should be very in a timely fashion. Like acute coronary syndrome, stroke, there is some golden hours. For sepsis also there are golden hours. So means basically right now the golden hours is within 1 hour the sepsis treatment should be started, and not only that, in some condition the antibiotics should also be instituted or administered if we diagnose that one. So first I will just try to cover how much of this. So if we come to the fluid therapy, about the fluid, how much fluid, and second thing, what fluid I will give. Usually there are different type of fluid like normal saline and isolate M, sometimes the isolate M. These are basically crystalloid. So in the crystalloid side and other side, sometimes albumin, gelatin, gelofuscin, all these things was available. So if we categorize these type of fluids, so normally right now we use the crystalloid. So either normal saline, or it may be a balanced solution like your isolate M or something like that. And question is how much fluid. Usually we 20 to 30 ml of fluid should be administered within 30 hours of the therapy. So that is very important. And that time actually how much fluid, when we are calling about that how much fluid, then only thing there may be sometimes some cardiac patient or renal failure patient may be there where you should be a little bit judicious. Otherwise for an average patient 30 ml per kg of body weight, usually we prefer within 1 hour 10 to 15 ml, and next 2 hours we usually give another 50% of the fluid. And about the when we are administering the fluid, so then there are basically about the fluid, normal saline was the gold standard, but right now in the last guidelines, this is the isolate M or the balanced salt solution, because normal saline contains too much of the chloride that can cause metabolic acidosis. But if we administer a balanced solution like usually isolate M, the chloride content is much less, so that's why it is preferable right now if it is available. But if it is not available, go for the normal saline. And albumin and other I'm just sorry, there is a bit, I don't know why it is happened. Some of the your slides there is change in the slide sequence. So about the isolate M, what I was discussing, that may be started, and the advantage is metabolic acidosis will be less, and after that the albumin, gelofuscin, Hester solution, these are not so preferred. About the monitoring means we are giving fluids, certain monitoring is necessary. That is the clinical monitoring is the key factor. So pulse, blood pressure, urine output, mentation, that is the clinical monitoring that we should practice. Along with that, sometimes if the facility for the lactate is there, you can monitor. Otherwise, there is capillary rippling time. So capillary rippling time is basically we are pressing the pulp of the finger and we are releasing it. Within 30 seconds, it should be actually that area should be red. But if that is not happening, it is like a blanching. That is an indicator that probably the peripheral circulation or the microcirculation is jeopardizing. That is one of the bedside that can be monitored. Though evidence is weak, but it is strongly recommended for these guidelines. And about the blood pressure, how much blood pressure? The mean arterial pressure should be 65 millimeter of mercury. So there are different type of recommendations, high or low, but 65 is the gold standard, and that should be achieved within the for 6 hours of the therapy. And right now it has reduced to within 1 hour we should actually reach that mean arterial pressure. And there are other type of monitoring like arterial blood pressure, CBP. If it is not available, so no problem. You give fluid, maintain with the just blood pressure, non-invasive method, and go for that. And about the antibiotics, so basically the antibiotics timing and what antibiotics you will give, that is very important. Antibiotics timing is basically the important is once you are diagnosing, first diagnosis is whether sepsis or infection or not infection. If infection, please give antibiotics then and there. And by the time, only one thing, if the patient is relatively stable, then send the respective cultures. If the patient is not stable, patient is either gasping or blood pressure is so low, means septic shock, so don't wait for that culture to send. So this is basically the clinical judgment is very important, and it is the mandatory that we should give antibiotics. But if the patient is not that bad and patient is relatively maintained, then you send the cultures as well as you try to find out whether this antibiotics is at all necessary or not. That is important. So timing is very important. I already discussed the timing is within 1 hour we should administer antibiotics, because if in septic shock patient every hour delay causes more than 10%, okay, less outcome in terms of the mortality and other thing. And if there is sometimes the diagnostic uncertainty in sepsis may be there. So if there is doubt, please treat them initially as sepsis and then send culture. Later you basically re-evaluate during the monitoring that whether continue to antibiotics or not. And not only that, the stopping of antimicrobial, when we can stop. So stopping is basically, we are giving antibiotics sometimes 10 days, 15 days, that is not necessary. If on our evaluation or daily round, the patient is relatively stable, and there is that basically right now we follow list or the duration should be within 5 to 7 days of antibiotics therapy, except on specific situation. So usually the earlier what used to happen, 10, 15 days patient used to get antibiotics. Right now 7 to 10 days is the maximum antibiotics that we may administer. And sometimes there is a doubt about sometimes C-reactive protein, procalcitonin. These are we are practicing in different institute. The procalcitonin for the diagnosis of sepsis is not recommended in this guideline. Only it can be used during the time when we are actually taking decision about stopping of the antibiotics. So about the antibiotics combination, what should be the combination? So I am coming. Gram-positive, gram-negatives are there. If there is a strong doubt about the antibiotics therapy that patient needs, so 2 antibiotics in septic shock patient is the mandatory. And in the 2 antibiotics, whether there is a doubt that this patient might have gram-positive, particularly MRSA coverage necessary. High risk means patient is in the hospital, patient is regularly visiting the hospital, or patient is on dialysis. So these are the some risk factor for the MRSA. So that time you can give a cover like vancomycin, teicoplanin, all these antibiotics. Otherwise, please.
Sir, 3 minutes are remaining.
Okay. 2 minutes. Okay. So about the antibiotics, 2 antibiotics combinations should be given, and that should cover basically, usually we prefer beta-lactamase inhibitor plus other group like a fluoroquinolone group, or sometimes some aminoglycoside. That may be if there is the doubt about the MRSA, so you can give the MRSA cover like vancomycin, teicoplanin. About the antiviral, there is no recommendations for the antiviral therapy. And about the antibiotics, how we can administer. So you give a bolus dose initially, full dose, and whether the patient is having a renal failure or not, don't bother about that. Usually most of the antibiotics, particularly beta-lactamase, the full dose should be given for 24 to 48 hours without any factor if there is any renal impairment. And about the beta-lactamase inhibitor, there are different type of antibiotics work. So particularly beta-lactamase, if you give a bolus dose followed a continuous infusion or a prolonged infusion like 3 to 4 hours infusion, that works better than giving an intermittent dosing. And in some antibiotics, particularly fluoroquinolone, aminoglycoside, give a higher dose in the initial phase. We call it as concentration dependent or time dependent. So concentration dependent, give higher dose and once daily dosing. And for the some antibiotics time dependent, you give for a prolonged infusion. So this is about the pharmacokinetic and dynamic, how you can use. And about the fluid type, I already discussed. About then the blood pressure medicine like norepinephrine, dopamine, and other substances like adrenaline that may be administered. fluid type I have already discussed. About the defined type of the vasopressor, the gold standard vasopressor is the norepinephrine, and this is the first choice, so please start it. And then if there is patient blood pressure is not maintaining, or you are gradually increasing the norepinephrine dose without any improvement, then you add the vasopressin. And in spite of that, patient is not responding, then you can go for the adrenaline infusion or epinephrine infusion. But there is no, for the dopamine, angiotensin 2, there is another new studies or research is going on. These are not. So gold standard is norepinephrine, add vasopressin, not working, then epinephrine or adrenaline. So about the other things, in spite of that, if patient's lactate is high, patient is not doing well, or there is some cardiac dysfunction, so you need some cardiac inotropic agent. So that time dobutamine is the only agent that can be administered in some cases. And about the whether the patient is having central line or peripheral line, no, don't bother about that. From peripheral line, you can jolly well give norepinephrine or any kind of the vasopressor agent. That is the message. And because sometimes I have seen that because of the central line, there is a delay of 15-30 minutes or sometimes 1 hour. And these are, I think, not may or may not be a. Sometimes the ventilation, about the ventilation, no ventilator, no problem. There is sometimes HFNO after COVID is available. You can offer that HFNO. In some center, there is basically non-invasive ventilation that can be offered, or oxygen may be offered. If that is not working, then you can go for the invasive ventilation. And about the invasive ventilation, I am not going in details. About sometimes the steroid is a confusion. So if the patient is not responding with the norepinephrine, or moderate or higher doses, okay, once the patient is on a moderate dose, not responding with the blood pressure response, then give the IV hydrocortisone. And sometimes there are other drugs like vitamin C, B1 or other supportive therapy. These are not helpful till date. So that is not recommended.
Time is up.
Okay. So just before ending, and there are other things I think more or less it's not so important, and only thing important is long-term outcome and goal of care on the day one should be discussed with the family, and what we are treating and what is the probable outcome. And finally, with that, we recommend that the clinical team should give an opportunity and discuss with the family about the final outcome, what it could be. And another thing is that, so what will be the, after recovery, sometimes the patient might have other consequences like critical care, neuromyopathy, or sometimes weakness, patient is not fit to go. So these are the important that should be discussed. And with this, I end my talk, and thank you for giving me this opportunity. If there is any question, then I can discuss. Okay, thank you.
Dr. Panja, for a brilliant presentation. I know it's extremely difficult to cover up the session in such a short time, but Sir has managed almost everything very nicely, and our entire session will be in YouTube. So if you want to see the entire session, you can see it easily. We are happy to announce we have launched our YouTube channel today. So I would like to request our chairpersons to felicitate Dr. Panja. Thank you, sir. This session was sponsored by Narayana Hospital, RN Tagore. Thank you. We conclude our second session.